Hello and welcome to chapter 15, Psychological Disorders. This is definitely not how I wanted to present this chapter, specifically because it is my favorite one. So I was hoping to be in class with you guys, but now that is not going to happen. Well, so we will just press on and make the best of this situation. All right, so let's just jump right in because there are a lot of things that we could cover. Well, we'd probably cover a lot more if we were together. All right, so we're skipping the vignette. All right, so you have two terms. You have psychological disorder and then abnormal psychology. When you look at abnormal psychology, that is actually a class. It's a field that is just devoted to studying psychological disorders. So if abnormal behavior and psychological disorders are something that you're really interested in studying, maybe specifically because you're going to be a therapist or you're going into the law enforcement agency and you want to know a lot about psychological disorders and triggers and stressors and things, then you would take a whole semester on abnormal psych. Okay, so what's normal, what's not? So it's really interesting because abnormal behavior, the difference between normal and abnormal is really easy. It's just what deviates from the norm. Whatever is normal in a society is considered normal, as long as it's not deviant, distressful, dysfunctional, and dangerous. So in order for something to be classified as a psychological disorder, there has to be all of these significant things going on in someone's life that are distressful, more days than not, that cause kind of a debilitating effect. It invades and impedes in your social functioning, your personal functioning, in work, and basically in all areas of your life. And those stressors will, or actually can, morph into those psychological disorders. So when you look at psych disorder versus abnormal psychology is basically just the field of study that you look into that is dedicated to looking at psychological disorders. All right, so when you look at the D's, usually in high school we say deviant, distressful, dysfunctional, and dangerous. In the college textbook, they use typicality. So that's the degree to which behavior is atypical, meaning rarely seen or statistically abnormal. Dysfunctional is when it interferes with your everyday life. Distressful is when it causes you to feel something inside that's not comfortable or it's very upsetting. And then deviance is where it's just doesn't necessarily mean like, oh, it's like you're breaking rules or whatever, but it is outside of the normal standard rule of behavior. So the question they pose is, can you think of examples where behavior is atypical but not abnormal? And then can you think of examples where behavior is deviant but not abnormal? And again, a lot of this you're going to see in cultural examples. All right, so on a continuum, anyone can have experiences similar to symptoms of psychological disorders. A lot of people will say, oh, I feel like I'm ADHD, or I feel like I have bipolar, or whatever. But it has to be on a continuum. It has to go from ranges of normal to abnormal, and it has to be consistent. So if things aren't just consistently abnormal, then it probably is just like an outlier. Some people have, not so good days. Things happen in life. So, and then when they talk about the historical concept, when I talked about in the very beginning of the course, there were different historical meanings of what psychological disorders were. An example, they talk about women's hysteria in the 18th century. So they didn't know different types of disorders, what schizophrenia was, they just thought people were crazy. So they either tried to drill holes in the brain or burn people at the stake and do all kinds of weird things because there wasn't a science behind it at that point in time. Okay, so cultural context, most disorders are universal, meaning that bipolar here is bipolar somewhere else. But there's also cultural syndromes whose symptoms and attributions appear to be unique to particular societies. So they give the example that Koro includes an unrealistic and intense fear that sexual organs will be pulled into the body. Now, of course, that is something that we here would find very abnormal, but in that cultural context, those are considered syndromes, and it's very unique to that society. So if you're entertaining, getting into this field specifically, you definitely want to take the multicultural class so that you can differentiate other cultures' beliefs and systems. All right, we're skipping the collaboration. Okay, so the insanity plea, that's a legal determination for, usually in a court of law to decide if someone is responsible for doing a criminal act. Those deemed legally insane are thought to have little or no control over or understanding their behaviors at the time they committed their crimes. So they're given psychological treatment in a facility in order to kind of get away from things like the death penalty. But right now in America, 45 states offer a form of insanity defense. But it's not that easy to get. You need a very good criminal lawyer to actually fight for that insanity plea. All right, stigma. Stigma is something we hear a lot in this chapter. We hear it a lot in, dealing with psychological disorders and therapy. But the stigma itself, the term, is a negative attitude or opinion about groups of people based on certain characteristics they have. And when there are stigmas, those often do lead to discriminatory behaviors or people being stereotyped or people being valued negatively. But the one thing to really understand are that people that do have psychological disorders are not violent. So usually in nature, they're not violent, but what we see in the media or in movies, Hollywood, they depict a very different kind of stereotype. The one I get a lot about, especially with DID, which is a very rare disorder, is a lot of people say, "Oh, have you seen the movie? What's the movie? Oh my gosh, I can't think of it now. The one where he has DID, starts with an S. I'm gonna have to split personality." Okay, so that, of course, there are little elements of that movie where you can pull some truth out of it, but for the most part, that is not how you would want to look at DID. They don't climb walls or turn into monsters. So just be very careful about that diagnosis and understanding that it is a very extremely rare disorder. Okay, so the DSM, you do want to know this. You want to know what the DSM is. It is the only manual used for diagnosing mental disorders. So it's called the DSM-5. That's the edition it is in now. It's the Diagnostic and Statistical Manual of Mental Disorders. And in order to be diagnosed with a disorder, it has to go through that classification. It's evidence-based. It's published by the APA, and there are 157 disorders. And of course, the benefits in looking at that book, because it doesn't matter how well versed you are in a disorder, it's important to still go into that when you're a clinician. And it helps the therapist, psychologist, whoever, develop a treatment plan. It does not contain treatment plans in there. What it does contain are, what does it entail? What are other things that it could be? Comorbidities, the percentage of people, with this disorder, other disorders that mimic that disorder, things like that. So it helps the clients obtain money back from their insurance companies when they are diagnosed. And it helps, insurance and clinicians kind of speak to each other on that level. But of course, with the DSM, you're gonna label people. So as a clinician myself, I won't necessarily say if somebody's suffering with anxiety or depression, it's not something I'm going to say, hey, you have depression, because I'm not going to label the person with what they're suffering with. My job is to help them find strategies to cope with the depression that they're feeling. So it's not, some clinicians will, tell people. I don't necessarily do that unless the client asks me, because again, my job is to help the client through that kind of a label, if you will, by not giving it a label. All right, so a label can change everything. So you can look at this more if you want. It's a really interesting study done by Rosenhan and 7 other people that he had part of the study, and they were mentally healthy, but they got themselves admitted into a psychiatric hospital by saying that they had these symptoms of schizophrenia, and they were told what to say, and then they had to actually get themselves out. So they were considered pseudo patients because they weren't real patients, but they basically faked having schizophrenia, got admitted, and then they had to get themselves out of it. So it was a really interesting study that I teach in my ACE class. But the average stay was 19 days. It ranged anywhere from 7 to 52 days before they were discharged. And then their charts basically just stated that they were in remission. So the question they pose is, what does this study tell us about labels and stigmatization of mental illness? So if you're really interested in studying psychological disorders, this is a really good study to look at. Again, it is the Rosenhan study. All right, so according to your text, this is basically the yearly rate of your major psychological disorders. So when they say anxiety disorders, they mean all of the clusters of anxiety disorders. Specific phobia means a very specific phobia, whether it's like, a phobia of spiders or a phobia of mustard. There's like a bazillion different ones. The only phobia that has its own special class is agoraphobia, and that is because it is considered the largest phobia out of all of the phobias. So you have social phobia, which is also considered social anxiety disorder. If you've ever heard of that, it's kind of interchangeable. Then you have your disruptive behavior disorders, your mood disorders like bipolar, major depression, substance disorders, which there are a ton, ranging from alcohol to opiates to cannabis to tobacco. There's a bunch of different substance use disorders, and then they just kind of clump in any disorder. So anxiety disorders are kind of like your highest ones that are the most prevalent. All right, so a term you will see a lot in classifying disorders, it's what's called comorbidity, and that is when 2 or more disorders are occurring at the same time. So usually if somebody is diagnosed with, let's say, ADHD, they might also be diagnosed with anxiety or substance use disorder or some type of other disorder. You will find that with most of the psychological disorders, they're kind of hand in hand with something else. So if someone is classified with anxiety disorder, they might also be classified with a depressive disorder. So in one study, being diagnosed with one disorder was associated with an increased risk of developing another one. All right, so when we look at the etiology of psychological disorders, you have the medical model, the psychological model, and then the sociocultural model. When you look at the medical model, that is looking at the biological standpoint, so the nature side of the debate. So that's looking at the genetics of diagnosable disorders, what's going on in the brain, chemical imbalances, with maybe serotonin levels or dopamine levels when it comes to depression, because a lot of these disorders are hereditary, like with your bipolar, schizophrenia. Usually when someone is diagnosed with one of those disorders, it's run down in the family. Either mom has it, dad has it, aunt, uncle, things like that. Your psychological factors all relate around cognitive things, personality characteristics, and mainly a lot of your childhood experiences will have a huge role in that, especially with your personality disorders. And then your sociocultural factors are all of like your social influences, more on the nurture side of the debate, looking at poverty, community support systems. You will find a lot of people that suffer with schizophrenia. Not only is it genetic, but there is a sociocultural aspect. When you look at high rates of like cities where there's a lot of poverty, you will notice that there's a high population of people that suffer with schizophrenia. All right, so 3 areas that you want to know. This is called the biopsychosocial model. And when a clinician does a diagnosis, when they first see a client, they will do what is called a biopsychosocial. And if you split that in 3, the bio, psycho, and social, your first meeting with a clinician, they may either have you do paperwork ahead of time like I do, and they will look at things like brain structure, genetics, neurochemical imbalances. And myself, like as the clinician, I will ask questions about family history. Okay, so who in the family suffers with this? Or I'm going to try to complete a overall picture by seeing what is going on the genetic side of the family. And then looking at the psychological side, I'm going to look at the person and look at like how they think, what coping strategies they use when they suffer with certain conflicts in their life, and then looking at their personality traits, because those very much align with people suffering with various disorders. And then of course the sociocultural, those are the rules and expectations that are expected of you, your model behaviors, and then of course culture plays a huge role in your belief system. So those 3 things all occur together. It doesn't, it's not included in a vacuum. So it's not all biological, it's not all psychological, and it's not all sociocultural. They all work together to form your disorders. All right, so you could look at this on your own over that. So again, when we look at anxiety disorders, when we see people that suffer with them, especially when they're very like overpowering and debilitating, these are disorders where the degree of dysfunctionality is so severe that it impedes on someone's life. So it causes a lot of dysfunction, it causes a lot of distress, it interferes with their everyday to-day life, and it can be very dangerous. So these are your anxiety disorders. These fall under the realm of that. So you've got separation anxiety disorder, and that occurs mainly with children. It can happen in adults, but it's very small. And this is anxiety or fear related to separation from home or an attachment figure. So maybe child wants to spend the night at their friend's house, they realize they can't go. So they cry, they scream, or they will call a parent or text them and find any reason to go home. It is so out of the range of norm that a lot of parents will end up staying home, or a parent will stay home because the child cannot cope with being away from that parent. And there's usually some triggers that are associated with that. And usually when we're in class, we'll have great discussion about, maybe somebody that had suffered with separation anxiety disorder, or maybe somebody that knows somebody with it. Then you have your specific phobia. Those are, like I said, there's hundreds of different types of phobia. Tryptophobia is one of the circles. I think those are, but this is a really interesting topic because everybody loves talking about specific phobias, and I love showing videos on them too, but of course we're not together to discuss that. But when you do have a phobia, it is out of the norm. You think that something is bigger than it is. And to treat these disorders, which we will get into later, there are ways to treat phobias, and it's through gradual kind of introducing that phobia to the person. Virtual reality is another way of doing that, which I will also go over. Social anxiety disorder, 7%. It's a big one, also known as social phobia. And that is extreme fear about being in a social situation, feeling that you're going to be judged by others. And that happens a lot in school. So if someone has an assignment due, or they have to do a presentation, they might either just take the F, or if they know that they have to present, they might not show up to school that day. So they do anything and everything they can to avoid that situation. And then panic disorder, those are recurring panic attacks that are unexpected and have no clue. There's no trigger. So sometimes people get panic attacks and panic disorder kind of misconstrued. They'll say, oh, I have panic attacks all the time. I start, I'm walking down the street and then I feel it coming. Well, with panic disorder, you don't know where it's coming. It is 1 minute you're okay, and 1 minute you are in a state of like, I am dying. It feels like an elephant is on your chest and you don't know where it's coming from. So there's kind of a difference between things like that and having an anxiety attack, things that are like building that it's happening, versus, panic disorder. So for any of you junkies like myself that are total psych geeks when it comes to psychological disorders, it's very important, especially if you're going to get into this field, that you really get schooled on knowing when to call something what it is and not misrepresenting what the term is. And then generalized anxiety disorder, that is anxiety and worry. It's not in proportion to anything that is anything to be worried about. So there is no actual threat to a situation. It's a lot, it's in your head, but to you, it's real. And generalized anxiety disorder is just one of those that encompasses kind of a general anxiety. All right, so again, panic disorder, sudden, comes out of nowhere. Shortness of breath, chest pain, nausea, lightheadedness, fear of dying. And then the panic disorder itself is the disorder that is given because of those unexpected panic attacks. All right, so looking at the etiology, so if we're looking at the nature side of the debate, the biology, involvement in hypothalamus, fight or flight response. So like I said, in every chapter, you're going to see that the brain and body, you're going to see some type of part of your body that's in here. So that the hypothalamus has the role in that, which is the fight or flight, and irregularities in the size and shape of the amygdala. So the amygdala is responsible for your fear response. Those are those two almond-shaped, pieces in your brain that are located in your temporal lobe. And then learning and panic disorder, some researchers propose that classical conditioning may be involved in the development of panic disorder. So a lot of what they're trying to say is that a lot of panic disorder comes from parents. So when parents put a lot of their anxiety onto their kids kind of like are conditioned to kind of, they're sponges, so they kind of take that on. So usually when I get clients with an anxiety disorder, I will immediately ask, okay, who's diagnosed with anxiety, mom or dad? Or if they're not diagnosed, who has anxiety, mom or dad, or both? So usually the person is, is telling me, oh, my mom definitely has anxiety, but she won't admit it, or she won't get help, or whatever the case is. All right, so your specific phobias, again, snakes are a big one. Again, it follows the learning theory. So a lot of these chapters morph into each other. So if you have a phobia of snakes, this definitely kind of morphs into or blends in with the chapter on learning. Classical conditioning can lead to acquisition, and operant conditioning can explain maintenance, which is negative reinforcement from avoiding the feared object or situation. And then, of course, you have the evolutionary perspective as well. All right, moving on. All right, so social anxiety disorder, also known again as social phobia, that's an intense fear of social situations or scrutiny by others. So if I asked you, if you were in a situation, what situations elicit your fear? And when you think of that fear, is it out of the norm? Is it out of proportion to honestly what is really danger? Or, is it really that big? Of course, to you, it's that big, but when you kind of like are sitting in a high chair looking down, is it out of proportion to reality? So often stems from preoccupation with offending someone or behaving in a way that reveals one's anxiety, frequently includes overestimation of the potential undesirable consequences of behavior. It's like giving a speech, you think everybody's judging you or looking at you, or, oh, they see me shaking, when really they're sitting there thinking the exact same thing. They're like, oh God, I'm next. Their last name starts with a B and I'm a C, so I'm up. So it's just, again, it's not anything to make light of, but these are things that once you learn more about these disorders, it's, this is really to help you understand that, we're all in the same boat. It's just some people have certain fears over others, and a lot of that is conditioning. All right, your generalized anxiety disorder, excessive worry about anxiety and activities related to family, health, school, and other aspects of life. So it's not social. It encompasses kind of everything. You'll have physical symptoms. It might be your muscles are tense, or you're kind of just fidgety and all over the place. And that's why they do a lot of twin studies, looking at heredity. And looking at different parts of the brain that show irregularities in the amygdala and hippocampus. And then, of course, your environmental factors like your childhood, and looking at overprotective parents, like helicopter parents. A lot of times when parents are too involved with their children, it puts a lot of that anxiety on their children, and then they grow up with that anxiety, and it's that vicious cycle I always talk about, that then you put that on your children. So there comes a point when you have to become educated and then decide, okay, this is where it stops. It stops with me. Okay, OCD, that's a big one. There's two types of OCD. There's OCD, that's in a class of its own. It is no longer under the classification of anxiety disorders because it's so prevalent that it gets its own chapter. So you've got OCD, and then you've got, in the personality disorder section, you have OCPD. So there are two distinct types of disorders. So your OCD is characterized by obsessions, which are in the brain, and then the compulsions, which are the actions. and they're time consuming and they're distressful, and it's more days than not. So just know the difference between obsession and compulsion. So your obsession is that repetition in your mind. It's intrusive. You don't want it there, but it causes so much anxiety and distress. And then, so it causes the act, which is the compulsion. And that's that mental act of, okay, did I lock the door? Did I not lock the door? Did I lock the door? And then that causes you to then go and check it a million different times. So it could be hand washing. That's a big one. It could be, checking the doors. It could be, what other things? Checking food, brushing your teeth, all kinds of stuff. But we see a lot of kind of unrealistic stuff out there. But excessive hand washing is one of the higher ones. So yeah, if you look at this chart, you'll see there's the obsession with symmetry, and that is having all things like look alike. Things like having all of the towels face a certain way, all of the cans face a certain way. Everything has to be in perfect order. When we look at worries about danger, oops, darn it, there we go. That's checking behaviors. So you've got counting behaviors to the left, we've got checking behaviors to the right, looking at, okay, I gotta check, I gotta check again. And then you have the obsession, worries about germs and contamination. So the compulsion is to clean to the point where your hands are raw and sometimes bleeding. And then to the right bottom, obsession. So those thoughts about sex and violence. And so compulsions then would lead to these mental rituals when it comes to like, all right, is this going to happen? Is that going to happen? If I do this, is this going to happen? So compulsions, what they're supposed to do is kind of reduce the anxiety by taking the obsession, turning it into an action. But unfortunately, what happens is it's a wheel. It just keeps going over and over and over again. So your OCD categories, the OCD that fall, so obsessive compulsive and related disorders means that under OCD, there's also these disorders. You've got body dysmorphic disorder, excoriation, hoarding disorder, and trichotillomania. So your BDD, that's when you're focusing on perceived deficits of one's appearance, which I'm going to pop on some videos for you. So like the human Ken doll, the human Barbie doll, where they do everything to change what they think are defects, but they're not. You look normal, and that's not to get confused with anorexia, although some people can, have those disorders together. Average onset is about 12 to 13 years old. Then you've got excoriation, that's skin picking disorder, where it's very unhealthy, and people start picking all over their skin, certain areas. Hoarding disorder, we've seen that in the show, Hoarders. And that honestly is just, you can't get rid of anything. There's no monetary value. There's no significance. It can be garbage. It could be just papers, but it's just the inability to be able to just get rid of anything. And then trichotillomania is pulling hair from the body. And usually it's the scalp, eyebrows, or lashes, but it can be like your arms, your legs, anywhere that there's hair. But those are the typical ones, or like, from your head or eyebrows and eyelashes. It gets a little more like on that strange addiction where this one woman had trichotillomania, but she also ate her the hair that she pulled from her body because she had an obsession with the bulb. So when you pull your hair out, there's like at the end, there's like this little bulb, and she would eat that, and her stomach ended up being like really bad. She had to have some surgeries due to that. All right, so again, the biology of OCD, reduced serotonin activity, locations in the basal ganglia, cingulate, gyrate, and orbital frontal cortex, they're all associated with that. First degree relatives with OCD have a twice risk of developing the disorder than first degree. And then the role of learning. Compulsions negatively reinforced by the reduction of fear. So they say that operant conditioning is a good way to help with people that suffer with OCD. PTSD, this is one that a lot of people say a lot that I don't really, again, ignorance is bliss. A lot of people I hear say, oh, I have such PTSD over that. It's not something I like to joke about. PTSD is very severe. It's characterized by exposure of being threatened by an event that involves death, serious injury, or violence. You have disturbing memories that consistently come back, nightmares, flashbacks. And this isn't like just something that's taken lightly. This is very debilitating. It's hard to sleep. It's hard to sleep next to somebody with PTSD because they will move. They can actually hurt their partner. And I know a lot of people that do have PTSD, they sleep in separate rooms than their husband or wife or intimate partner because it can be dangerous. War and rape, sexual assault is high risk for PTSD. One study found that the rate of PTSD in prison populations is 48%, and probably due to things that go on in prison. For U.S. veterans 21 to 59 years old, the current rates of PTSD are around 8%. So there are things that do help with PTSD, but that's why you'll see signs sometimes during 4th of July or Memorial Day that somebody outside of their house will put a sign that says a veteran lives here. So, most people know this, but if you didn't and you wonder why, that's because they're probably either taking Valium or some type of pill or putting, the pillows under their head, because when they hear the pop, pop, pop of the fireworks, it brings them back to a wartime. A really good movie to watch is American Sniper. I really like that movie with Bradley Cooper because he had PTSD in that movie. All right, so diagnostic criteria: distressing, disturbing, spontaneously recurring memories of the event, dreams with content or emotions associated with the event, dissociative reactions, so kind of like having flashbacks and just kind of dissociating from yourself in that moment, a lot of distress and reminders of that event. And then, of course, you're going to have physical reactions. And it could be, there have been occurrences where, husbands have choked their wives in the middle of a PTSD event, actually killing their wives. There was one case that I know of. I mean, there's multiple, but one that I know of where a husband had, a flashback, and he grabbed his gun and he thought something was happening and he shot and killed his wife. So he did get off on those charges because he really was having a flashback. So it is not something to be taken lightly. So I don't like hearing people that casually just say, oh, I have PTSD, because it's not a fun disorder, and it's not something to be made lightly or make fun of. Major depressive disorder, that's an evident in if 5 or more of the listed symptoms happen, occur for at least 2 consecutive weeks and represent a change from prior functioning. So it has to be 2 consecutive weeks. It has to cause significant distress or impairment. It's not due to any other medical or drug-related condition. And you will find with a lot of these disorders that criteria has to be wiped out. So it's not because of medical situation or any drug-related condition. That has to be ruled out. Often can be challenging because, again, depressive disorders, they vary across cultures. So again, if we were in class, we'd be able to discuss more about varying degrees of depressive disorder, because there's major depressive disorder, there's persistent depressive disorder, and then there's what's called like dysthymia. So symptoms: depressed mood that might result in feeling sad or hopeless, reduced pleasure in activities almost all of the time, substantial loss or weight gain weight or loss without even trying, changes in appetite. It's because the stress causes you to lose the weight. So you're not even trying. sleeping excessively or not sleeping enough, feeling tired, or having just this debilitating loss of energy, feeling worthless, or, just always feeling guilty, not being able to concentrate, and then, consistently thinking about death or suicide. And again, the one thing I tell people, and this I want you to know, is suicide does not happen usually when someone is in a depressive state. That's actually the least time that it happens. It happens when someone is coming out of their depression, because now they actually have the energy to follow through with it, because they know that that depression is going to sink again. So once they finally start getting better, it seems that's when if they're going to, they carry out with it. Major depressive disorder, most common and most devastating. In the US, the lifetime prevalence is 16.6 to 20.6%, beginning in adolescence, and 1.5 to 3 times higher for females than males. American ages 15 to 44 is going to be your highest rate. Risk factors for suicide are previous suicide attempts, family history of suicide, because it is genetic, it does cross over, alcohol and drug abuse, physical illness, history of depression, and that's with other family members too, and then feelings of loneliness. So it's really important to kind of keep in check when you notice people have kind of these check marks, or giving things away, or saying I don't have the will to live, or talking about suicide. So you want to help them, talk to them. It's not your job to fix them, but try to have them seek out help. So why do people kill themselves? It's not because they're selfish. Quite the opposite. They feel in their mind that they're doing the world a favor. So having a genetic predisposition for suicidality, with environmental assaults of the will to live, they just want the pain to go away. They feel like they are a burden to people, and if I'm just gone, then nobody will have to worry about me anymore. 43% is linked to genetics, so that's important. 57% is attributable to the environment. So it's that nature nurture. Often don't understand the reasons for our depression. It leads us to make misattributions. So example, it's because of what others said or did. So we often take what other people do or say, we put that on ourselves, leads to depression, and then we just feel like no hope, and then I just want it to be done. Our situations often look different months later due to medication, change in circumstance, or gain perspective. That's why it's really important that when people are feeling this way, to just say, hey, I'll go with you if you want to see a therapist. Because once they kind of get through that little hump and get on medication, then they're not going to feel that way anymore. It's when they feel in the pits of despair that they just don't have the will. So if you know somebody like that, please don't ever think that oh my God, if I tell somebody this is how I'm feeling, they're going to Baker Act me, or they're going to think I'm crazy. It's if you're having these thoughts yourself, or if you know somebody that does, that's what the suicide prevention line is for. They're there to talk to you, work with you, and try to get you connected with somebody. I used to work for Brevard 211, and I worked on this suicide hotline. And so that is what I did, was I talked to people through things. So please don't get that misconception that if this is how you're feeling, that you're going to be labeled and you're going to be put away in a straitjacket, because that is not what it's about. All right, so again, genes, hormones, neurotransmitters, twin studies are looked at a lot. Higher levels of cortisol and hyperactivity of the HPA system are linked to major depressive episodes. Lower serotonin levels, your abnormal activity in those neurotransmitters, so norepinephrine, serotonin, and dopamine. So that is the reason why you try different depression medications to see what works for you. Some depression meds don't work, so you have to try other things until you find what works for you. And it's linked to the shrinking of the hippocampus, which is, it looks like a seahorse, which is also in the temporal lobe. All right, so learned helplessness is another factor. Martin Seligman, you can look at this on your own, a study that he did with dogs and feeling defenseless, and he transferred it over into humans. And it's basically when you feel like you have no control over anything, and that it results in this passive behavior. You've gone in relationship after relationship, and you feel like this one's going to be different and that one's going to be different. And then when it's not, it's like, you're just like, forget it. So you have this like learned helplessness that, okay, it's not going to change, so I might as well just stay and I'll just go with it. And so that when that happens, you've got this negative view of yourself, the world, and everything that's going to happen. So you just ruminate over these things, and until your mindset changes and you experience, positive, which Martin Seligman then morphed into positive psychology. That's where his kind of work with learned helplessness he wanted to know, okay, well, how do we get out of this? So he, was one of the founders of positive psychology. So it's really interesting if you're interested in looking at that and why we make these same mistakes and what makes us choose the same people expecting different results. Could be due to learned helplessness, which is why a lot of people in domestic violence situations, they stay not because they deserve it or not because they like it. It's because they just don't believe that there's a way out. All right, bipolar disorder. So bipolar, you've got mania and depression. It used to be called manic depressive disorder, but they felt that it was too stigmatizing, so they called it bipolar. So two polarities, mania and depression. So during the manic phase, there's bipolar 1 and 2. Bipolar 2 is the lessened version. So it's continued elation, so highs, irritability, high levels of energy and expansive mood. You don't need a lot of sleep. And during one of these manic episodes, a person exhibits 3 or more of the following. So you have to have 3 or more in order to be diagnosed with bipolar. So grandiose or extremely high self-esteem. So your self-esteem is through the roof. Reduced sleep, increased talkativeness, flight of ideas, all these racing thoughts, easily distracted, heightened activity at school or work, physical agitation, displaying poor judgment, engaging in risky behaviors. The 2 risky behaviors are sex and shopping. Those are the 2 main ones. And people that suffer with bipolar a lot will go not undiagnosed, but untreated, because they will deal with 6 months of depression, 3 months of depression or whatever, just to have maybe that couple weeks of mania, because when they're in their manic phase, they feel like they're on top of the world and they can do anything. And a lot of corporate CEOs suffer with bipolar, and they go unmedicated because some of their greatest ideas come out of their bipolar or out of their manic phase. So it's not healthy, but it's just a reality. So bipolar 1, again, that's the prevalence, that's the description. When it comes to the second bipolar, at least 1 major depressive episode lasting 2 weeks, as well as hypomanic episode, which is just a lower version of the mania, and that has to last a minimum of 4 days. So you can kind of look at this chart and see the difference between bipolar 1 and bipolar 2. Bipolar cycling. Some people with cycling, they go from highs to lows for days, weeks, or months. Periods of mania and depression may be brought on by life changes and stressors. And some research suggest it's only the first episode that tends to be triggered by some sort of life event. So the first episode of bipolar is triggered by an event, and then not necessarily after that. And then when we look at the molecular look at the brain, and you can see like who gets bipolar disorder, what bipolar disorder looks like when you're under a scan. Again, a lot of it is genetic. It correlates, biology correlates with, it doesn't mean it's caused, but it's definitely a correlation. So adults who have first-degree relatives with bipolar, on average, have a 10-fold increase for developing the disorder themselves. And then we look at the environment. So you could look at the environment there. Moving on to schizophrenia. Again, people think schizophrenia is split personality, not to be confused with MDD, or not MDD, but DID. Loss of contact with reality. So it's kind of like a split from reality. You have this disturbance in thoughts, perceptions, and language. Excellent movie to watch is A Beautiful Mind. People with, schizophrenia, that I want you to understand, it is not DID. Lots of people confuse the two. Split personality, which is not that. It's the two main things with schizophrenia are delusions and hallucinations. And mainly people have auditory hallucinations than visual. So when you look at it, there's positive and negative. And even though it seems like, what? Your positive are the delusions, hallucinations, disorganized speech, like word salad, grossly disorganized catatonic behavior, and then abnormal motor behavior. The negative symptoms are decrease, so just kind of like there, no motivation, decreased speech production, could be catatonic, decreased functioning at work, calling off work, not going into work, not being around social situations, not taking care, not showering, not brushing their teeth, doing none of those things. And then reduced pleasure and lack of interest in interacting with others. All right, so to be diagnosed with schizophrenia, you have to display the symptoms more days in a 1-month period, and experience significant dysfunction in work-school relationships for at least 6 months. It is uncommon. It's 0.3 to 1% lifetime risk. Although men and women appear to face at equal risk, the onset occurs earlier in men. And then schizophrenia disproportionately affects people of lower socioeconomic classes, like I stated before, which is why you will see a lot of the population in lower socioeconomic statuses. This is an interesting study of 4 quadruplets who all were diagnosed with schizophrenia. So if you want to look in the book or look in this case, the Janine case, it's an interesting study. This just breaks down the who gets schizophrenia. You'll see at the bottom, identical twins have a higher rate, and then it kind of moves up the ladder. All right. The dopamine hypothesis is really big with schizophrenia. Theory suggesting that the synthesis, release, and concentration of the neurotransmitter dopamine plays a role in schizophrenia. So dopamine is the one that's responsible for schizophrenia for the most part. I mean, that's what they look at is in that hypothesis. Environmental triggers can be exposure to a virus when a woman is pregnant, or complications at birth, having social stress. Cannabis abuse can be a slight risk for schizophrenia at the onset. Autism spectrum disorder, a big one to talk about, ASD, that occurs in 59 American children. There are various levels. If you were diagnosed with Asperger's syndrome, that no longer falls under the category of autism. Under that spectrum, it is just considered, high functioning, low functioning, but there are different types. 4 times more common in boys, and the causes still unknown, but more research is showing again that it runs in families and that it falls more on the father's side than the mother's side. And it is a neurodevelopmental disorder, not a psychological. And then your personality disorders. Oh my gosh, we could go in a lot over personality disorders. Those are amazing to talk about. You have your cluster A, cluster B, and cluster C personality disorders. So I'm going to run through these really quick because we're running out of time. But your cluster A are your paranoid, schizoid, schizotypal, and or disorders. Then your cluster B are your antisocial, borderline, histrionic, and narcissistic. Those are your most dangerous personality disorders, the most difficult ones to treat. And then your avoidant, dependent, and obsessive compulsive personality disorders. So you can go ahead and pause or look at the still video and look at these. Antisocial personality disorder are the ones that most of your serial killers suffer with, like Ted Bundy, Jeffrey Dahmer, all of those. They have no empathy, lack of any type of, they could kill you, stab your face, and then eat dinner and go home. They typically do have wives, lead normal lives. They're very, a lot of them are very narcissistic, and they're just very impulsive and deceitful, and they're very charming. But your first three are like your paranoid ones, and your next four are your I don't need help, it's not me, it's you. And then your last three are the ones that are like your you avoid things, or you need things, or you're obsessed with things in that personality disorder realm. And I might pop in another video just to kind of go in depth a little more with the personality disorders. So again, etiology, a lot of these, they're hereditary. There's no rhyme or reason. There are regularities in the frontal lobes. And again, it's that whole nature nurture debate. More women suffer with your like borderline disorders and your histrionic, versus males suffer more with your antisocial and narcissistic disorders. Borderline, again, I am going to cover this a little more in another video just on these disorders because I think it's worth going over more in detail. So I'll pop a second video in for these. As well as I'll go more into DID, and I will include a lot of videos because, again, to wrap this up in an hour is really difficult, but these are very interesting disorders and ones that I want you to know about that you would be interested in. Okay, so I will cover that. I'm also going to hit on the eating disorders so that you have a little more information about the differences between anorexia and bulimia. But for the purpose of this, you can look at that. And just know that there is anorexia, bulimia. There's an anorexia with binge eat type. So you can't be diagnosed. You can diagnosed with both, but it has to be anorexia binge eat type, because like I said, I'll get into that in another video. But those are just kind of how you can associate. Anorexia is what's pictured. They're very thin, but they see themselves as heavy. And then bulimia is eating and throwing up, or eating and taking laxatives, etc. And then there's the newest one is binge eating disorder. So I will cover those types of things, and that's the end of the video. So I did it all right under an hour. But again, I'm going to pop in a second video because I think it is important to give you a more overall clue into some of these disorders. And again, if you have any specific interest, please email me and let me know what your interest is, and I will provide you with more information, because this is what I specialize in my practice, are psychological disorders, obviously. So with that said, I will end this video and look out for the next one coming out. All right. And I'm going to do my peace sign the right way. So with that, peace.